Okay. So the whole last section, the whole rest of this chapter is on cardiodynamics. And cardiodynamics is all about the factors that affect cardiac output. So the force that's generated and the way that we generate that force in order to affect cardiac output, or literally how much output comes from the heart, how much blood we actually pump. These first few things you guys are already familiar with. We're just going to kind of review them really quickly so that you guys are comfortable with it because they're going to be important. We talked about the end diastolic volume and the end systolic volume when we talked about a cardiac cycle. What's diastole? Relaxation, right? So the end diastolic volume is the volume in the ventricles at the end of diastole, at the end of relaxation. So it's filling up when it's relaxed, right? So at the very end of that diastole, when it's completely filled up, right before it enters systole, that's the end diastolic volume. Okay, so that's literally, again, the max volume. That's the most that we're going to put into that ventricle in that one cycle. Okay, it's filled up. End systolic volume is the minimum volume, right? So that's the volume that's left over in the ventricle at the end of systole. And what's systole? Contraction, right? So after the ventricle contracts and pumps blood out, there's something left. It's not empty. That volume that's left over, its minimum volume, is its ESV, or its end systolic volume. And the difference between the two is how much it pumped out, right? And we call that the stroke volume. So the amount of blood that's pumped out of the ventricle, right, during one cycle, one contraction, is the stroke volume. Again, we said that the stroke volume is the difference between the EDV and the ESV. So the maximum volume that you put in minus the minimum, the amount that's left over, is going to tell you how much you pumped out, right? The ejection fraction, we utilize the ejection fraction a lot when we're evaluating the efficiency of the heart, or how well the heart's functioning. We use ejection fraction specifically in heart failure when we're monitoring the progression of heart failure, saying does the patient actually have heart failure or not, how severe is the heart failure. We'll look at the ejection fraction, the F. The ejection fraction is the percentage of the EDV that's represented by stroke volume. Okay, that sounds confusing, but essentially it's just the percentage of your max that you actually pump out. Okay, the percentage of that end diastolic volume, that maximum volume that you're actually ejecting from the heart. Okay, the higher that number is, the more you're actually pumping out, right? You can cram a bunch in, you want to be able to pump it out as well. You don't want to be cramming a bunch in and barely be able to get any out. That doesn't do you any good. So just these numbers aren't right, but if you wanted to calculate it just to make the numbers easy, if my end diastolic volume, the amount that I put in was say 100 milliliters, and my stroke volume, the amount I pumped out was say 40 milliliters. Okay, what percentage does 40 represent of 100? 40%, right? So my ejection fraction would be 40%. That's heart failure. That's not great. You don't want to have an ejection fraction of 40%. But that at least makes the math easy for us. That's how you calculate the ejection fraction. So cardiac output is the volume that's pumped by the left ventricle in 1 minute. Okay, so the output from the heart, essentially. How much blood are you actually sending out to your body in a full minute? The way that we calculate cardiac output is stroke volume times heart rate. Okay, so heart rate is literally how many times does your heart beat in 1 minute? The stroke volume is how much are you pumping out each time. Right, so it makes sense if you multiply that volume by however many times you're pumping it out, that's going to give you the total volume that you're pumping out of your heart in 1 minute. The heart rate we do in beats per minute. So if we were doing cardiac output, and say the heart rate was 80, and say the end diastolic volume was 80, and the end systolic volume was 40 mLs, and that's beats per minute. So if I wanted to, and you should be able to do this, okay? If I wanted to calculate the cardiac output, I said cardiac output is heart rate times stroke volume. So my heart rate is, we have that, that's easy, right? 80 beats per minute times, I don't have my stroke volume here. How do I get my stroke volume? Super basic, right? Max minus min, so EGV minus ESV. This is how much I crammed in, then I pumped something out, and this is what was left over, right? So the difference between the two is telling me how much I actually squeezed out. So what would that be? 40 mLs per beat, right? Like 40 mLs per beat. So 40 mLs per beat. Okay, so my beat and beat are going to cancel, and that leaves me with mLs per minute. And what's 80 times 40? 8, 16, 24, 32. 32, and then minus zeros. Right? Is that okay? So that would be my cardiac output. Right? 3,200 milliliters per minute. Again, be able to do it like with super simple math. It'll be really, really easy math, but be able to calculate it. Or if I just straight gave you stroke volume, I might just give you the stroke volume. I might give you the stroke volume and the end diastolic volume. So don't get confused and start subtracting the stroke volume from the end diastolic volume. Understand which volumes you use and why, and how you would calculate cardiac output. So cardiac output. What's cardiac output? God, that's a lot of mumbling. How much blood is coming out of the left ventricle in 1 minute, right? So how much blood you're sending out to your body in a minute. How do we calculate it? Heart rate times stroke volume. Obviously, at times we have to alter our cardiac output, right? Your body is not always needing the exact amount of blood. If you're sitting around not doing much, your muscles don't need that much oxygen and glucose. If you start running, you better believe your muscles need to be fueled. Right? If you eat a huge meal, you need to bring a lot of blood supply to your intestines. We alter how much cardiac output we need and where we need it to go. We can alter cardiac output by altering either one of these components. Right? We can change the heart rate. If we change heart rate, obviously that's going to change cardiac output. Right? They're going to vary the same. If we increase heart rate, what would we do to cardiac output? Increase it. If we decrease heart rate, what would we do to cardiac output? Decrease it. Same thing with stroke volume. Right? How much you actually pump out of the heart, you can change that. You can pump more out per beat or less, depending on your needs for cardiac output. So we can adjust the stroke volume, how much we pump out. And again, that varies along the same plane. So if we increase stroke volume, what do we do to cardiac output? Increase it. If we decrease stroke volume, what do we do to cardiac output? We decrease it. So we're going to spend the next few slides kind of looking at the different ways that we can adjust heart rate and the different ways that we can adjust stroke volume in order to adjust our output. So back to the nervous system. We can adjust heart rate by adjusting the input from the autonomic nervous system. Okay, if you guys remember the autonomic nervous system, it's got two divisions. Can you tell me what they are? Sympathetic and parasympathetic. Okay, so the sympathetic nervous system and the parasympathetic nervous system both help to control heart rate, how fast your heart beats. We have the cardiac centers up in the medulla oblongata, and if you remember, those cardiac centers included a cardio-acceleratory center and a cardio-inhibitory center. And the names tell you exactly what they do. They accelerate the heart rate, or they inhibit or slow down the heart rate. So when we look at the cardio-acceleratory center, that's going to control sympathetic neurons. What was the nickname we gave to the sympathetic nervous system? Fight or flight. Okay, so that's active, right? That's if somebody surprises you and you have to fight or you have to run. Right? When you're running, when you're exercising, when you're uppity, right? What do you, just think about it. Someone scares the crap out of you, what happens to your heart rate? It increases, right? Your heart starts pounding. You don't get super relaxed when you're scared, right? Your heart starts pounding. So this makes sense. The cardio-acceleratory center controls sympathetic neurons that are part of our fight or flight system. When these sympathetic neurons are stimulated, they release norepinephrine onto the SA node. And that norepinephrine increases your heart rate. What's that going to do to cardiac output? That's going to increase cardiac output. Right? You've got to run, your heart's going to start pounding. It's going to start beating really, really fast to pump more blood out to deliver all the nutrients that you need to your muscles so that you can do whatever it is you need to do. Okay? The cardioinhibitory center up in the medulla controls the parasympathetic neurons. What did we call that system? Rest and digest. You eat a huge meal and you get tired, right? It happens. It's not just like some myth. You eat a big meal and you get tired. All your blood flow, not all of it, but a lot of your blood flow gets diverted to your abdominal organs, to your GI tract, because you need to process and digest that food. You need to absorb all of those nutrients. So the blood flow goes there and everything else gets kind of like, oh. When you're all relaxed, what happens to your heart rate? Goes down, right? So this makes sense. When you're resting and relaxed, when the parasympathetic neurons are releasing acetylcholine onto the SA node, that slows your heart rate. Okay, what would that do to cardiac output? That could decrease cardiac output. Remember, guys, too, that these are just adjusting heart rate. Okay, what sets the basic pace for your heart? The SA node. Remember, the SA node can beat, it can generate contractions without these. These neurons don't have to tell it to contract. The SA node sets its own basic pace, and then we alter that based on how much norepinephrine and how much acetylcholine we're releasing onto that node. Now, we always have some tone. We always have a little bit of norepinephrine and a little bit of acetylcholine being released onto the SA node. Okay, so I'm kind of skipping right here and then we'll come back up to the top. We call this autonomic tone. We maintain some tone, some autonomic input to the SA node from both the sympathetic and parasympathetic nervous system all the time. So you don't start at zero. And the reason for that is it allows for more kind of intricate adjustments of the heart rate. So I think the easiest way to explain this is like if you started at zero and you need to adjust your heart rate, the only thing you can do is add more, right? Like if I start at 0 acetylcholine and 0 norepinephrine going onto the SA node and I want to speed up my heart rate, all I can do is increase the norepinephrine, right? Because my acetylcholine's already at 0. I can't do anything to it. All I can do is increase the amount of norepinephrine. However, if I have both of those going onto my SA node, say I have a level of whatever, it doesn't matter, 3 of both acetylcholine and norepinephrine, and I want to increase my heart rate, now I can increase my norepinephrine, and what else can I do? Decrease my acetylcholine. Okay, so I can do a quicker response, a more kind of efficient response, because I already have some tone, some level of both neurotransmitters going on to that SA node. Okay, that allows us to adjust either up or down. Obviously, when we're resting, the parasympathetic nervous system dominates, right? So that would be acetylcholine with a nice, slow, level heart rate. When we're exercising, the sympathetic nervous system is going to dominate. So in that case, we would have more norepinephrine going onto that SA node, and we would have a more rapid heart rate. So how do these neurons know what to do, right? They need to know when the sympathetic nervous system needs to release that norepinephrine, or when the parasympathetic nervous system needs to release that acetylcholine. These neurons are controlled by 2 different types of receptors. We have baroreceptors and chemoreceptors that are present, that send signals up to the cardiac centers, and then the cardiac centers send signals down to adjust heart rate. Okay, so this whole thing starts at these receptors that monitor our blood pressure and monitor the chemical concentrations in our blood. So for example, baroreceptors monitor blood pressure, like a barometer measures the pressure of the air, right? Baro is referring to pressure. So the baroreceptors monitor our blood pressure. If the baroreceptors detect that the blood pressure goes down, okay, if blood pressure goes down, the receptors send a signal to the acceleratory center, the cardioacceleratory center. Okay, what does the cardioacceleratory center then do? What does it release? What does it release? Good job. So the cardio-acceleratory center releases norepinephrine onto what? Onto, I wrote S, onto the SA node. And what does that do to the heart rate? That increases heart rate. We haven't talked about blood pressure yet. We will when we do vessels next. But you can imagine that if we increase the heart rate, we start pumping out more blood. More blood might increase the pressure, right, in the vessels. You imagine if you put more volume into something, it's more pressure, okay? Or the opposite would also be true. So if the blood pressure goes up too high, we want homeostasis, right? So our body says, wait a minute, that's too high. We need to find a way to decrease this pressure. How can we do that? So the baroreceptors would send a signal up to the cardio-inhibitory center. What would that release? Good. That releases acetylcholine, the parasympathetic neurotransmitter, onto what? The SA node. And what does that do to heart rate? That decreases heart rate. We decrease heart rate, we decrease cardiac output. Now we're cramming less blood into the vessels, so that decreases the pressure that's present in them. Okay, it brings us back to homeostasis. Chemoreceptors sense chemical concentrations. So what chemoreceptors are sensing are the concentrations of oxygen in our arteries. We have these mostly like right at the very beginning of the aorta and then also up in the brain as well. But we have them that sense the concentrations of oxygen, the concentration of carbon dioxide, and the pH. And it's kind of interesting. Again, we'll talk about this next chapter and when we do respiratory. But we always think like oxygen's the most important, right? Like we would alter respirations, we would alter blood flow, all based on oxygen. But pH is actually the most important. We alter it mostly based on pH, then carbon dioxide, then oxygen. But again, we'll talk about that more later. In any case, though, we're going to alter our heart rate and cardiac output according to these concentrations. So let's say we have too much carbon dioxide. We have too much CO2. Just thinking really generally without knowing anything, what are you going to want to do to get rid of it? Breathe, right? So you need to get that blood moving faster to carry it around the system into the lungs so that you can exhale that waste. So you need the blood to move more, right? Because a waste product is building up. You need the blood to move to get rid of the waste. Is that okay? Okay. So we want more blood to move. We want to increase cardiac output. So if our chemoreceptors sense that we have too much CO2, then they're going to send a signal to the cardio-acceleratory center. What does that release? That releases norepinephrine onto the SA node. And what does that do to heart rate? Increases heart rate to increase cardiac output to get that blood moving so that we can get rid of the waste. Is that okay? Those reflexes? In theory? Okay. So how, right? How is it that norepinephrine speeds up the heart rate? How is it that acetylcholine slows down the heart rate? We've got to take a second and kind of think back to these conduction cells in the SA node and remember how they work. And then we can look at how it is that we might speed them up or slow them down. Remember the conduction cells have a different resting and threshold potential than the contractile cells. Contractile were -90 and -75. Remember we said the conduction cells, the resting potential was -60. Threshold potential is -45 millivolts. So I have a cell. This cell sits at -60 millivolts at rest. How does this cell depolarize? Like what happens? It's a pacemaker cell. Leaky channels. It's got leaky channels. What leaks in? Sodium. What charge is that? Good. So positively charged sodium leaks into the cell, right? So we would typically start right here. We have to let the sodium leak into the cell slowly. Once it gets to threshold, then we open up our voltage channels, we depolarize really quickly, and then we repolarize back to 60, and then we leak, right? That's what would normally happen. So when the parasympathetic nervous system starts releasing more acetylcholine onto, here we go, more acetylcholine onto the SA node. What it does is it hyperpolarizes the cell. So if you look here, instead of this cell just going back down to -60, which is where it would normally go, instead, this cell, it leaves open the potassium channels longer. And remember, that's what repolarizes it, right? We open potassium channels, potassium leaves. When you take positive charges out, it gets more negative. So if you leave those potassium channels out open for a longer period of time, more potassium leaves. So when you look at this repolarization, look, it goes down to -60, and then it goes down even further. It hyperpolarizes. It gets more negative than it normally would. So here, it only had to leak 15 millivolts, right, to get to 45 and to have a contraction. Here, look, we're way down here. We're at like -70 millivolts. Now I have to leak 25 millivolts. That's a lot more. Okay, so it's harder, it takes longer. So now instead of, depolarizing in this amount of time and then contracting, it takes this long. It takes twice as long to depolarize. So now instead of having a second in between contractions, I have, 2 seconds in between contractions. All right, so it slows down your heart rate by hyperpolarizing the cells in the SA node. It takes them longer to depolarize. Some texts, there's kind of some discussion here on these, the way that this happens. Some texts say that it also slows depolarization, so it slows down the inrush of positive charges, like the sodium, the calcium that enter. It slows that down, and that would also lengthen it. Okay, but I'll just ask you the stuff that I've kind of avoided here, and the stuff that I put on my review. Is that okay? You kind of have to understand how it works to understand how we adjust it. So if you didn't understand the first part on how it depolarizes, this is going to be pretty difficult. This is the opposite. So this is what happens when the sympathetic nervous system predominates on the SA node. Okay, again, we normally rest at -60. We've got to get to -45 to stimulate an action potential, right, to have contraction occur. When the sympathetic nervous system predominates, remember this releases norepinephrine, and the point is we want to increase the heart rate, right? So we want to stimulate it faster. We want it to get to that threshold voltage even quicker than it normally would. So we reduce the repolarization, right? If we go really polar, we slow it down. If we go less polar than we would have, we speed it up. So here you see when we normally, like potassium leaves the cell, we said to repolarize. So potassium's leaving, potassium's leaving, potassium's leaving, and we stop, or we close those channels before we get to -60. So now if you look here, we're at, I don't know, say -55. So if you, or -50. So if you look at this, before we had to leak, the sodium had to leak to bring us all the way from -60 up to -45. We had to change 15 millivolts. But if I close those potassium channels at -50 millivolts, now look, I barely need any sodium to leak in. It doesn't take very long for only 5 millivolts worth of sodium to leak in. That happens really quickly. Okay, so if you reduce the repolarization and you don't get as negative as you typically would, then you're really close to threshold and you can depolarize again really, really quickly, so the heart beats very, very rapidly. Is that okay? Okay. Oh, this is just showing you some texts will say that we allow more calcium to come in, so while we decrease the positive charges we allow some positive charges in, but again, it varies based on the text you're looking at. So I want you guys to know the potassium bit, because that is like a definite. The other ones are kind of like, depends on where you look. Another way that the autonomic nervous system can adjust heart rate is via the atrial reflex, or the Bainbridge reflex. So this adjusts heart rate in response to venous return, so the amount of blood that's coming back to the heart. So just picture this, if, like, say you're super, super active, Hey, if your muscles are working like crazy, like I'm running, your muscles start working like crazy, they literally pump the blood back to your heart quicker. So you get all this blood coming back to your heart, and it's all trying to cram into the atria, right? There's like a backlog of blood. So your heart needs to start pumping more to move it all forward again, right? Because everything's getting backed up at the atria. So what happens is that when all this blood's getting crammed into the atria will stretch. Okay, they'll stretch more. Okay, a ton of blood shoved into the atria, they're stretching out with that increase in volume. That triggers stretch receptors, these little receptors that are in the wall of the atria. Okay, they send a signal when you stretch them too much. They send a signal up to the cardiac centers in the brain. Okay, specifically the cardioacceleratory center. What does the cardioacceleratory center release? That increases norepinephrine, right? Or sympathetic neurotransmitter. Norepinephrine, remember, goes down to the SA node, right? And increases heart rate. What happens to cardiac output when we increase heart rate? We increase it. So we get rid of all that blood that was backed up, right? We're pumping more out and we push it all forward again. So then the atria aren't stretching as much, right? They've got their normal volume coming in then and everybody's fine. Is that okay? Okay, so the cardioacceleratory center can be turned on by changes in blood pressure, right? It could be turned on by these stretch receptors in the atria. It could be turned on by changes in chemical concentrations, right? Like an increase in CO2 or a decrease in pH or something like that. There's a lot that can kind of stimulate these cardiac centers in the brain. All right, so that's heart rate. What did we say? How did we calculate cardiac output? Heart rate times stroke volume. So we just saw there's a lot of different ways we can adjust heart rate, right? Via acetylcholine or norepinephrine, we can either speed it up or slow it down. And that's one way that we can adjust cardiac output. We can also adjust cardiac output by adjusting the stroke volume. Okay, that's again how much we're actually pumping. So not how many times, but how much we're actually squeezing out. So there's a few different things that we'll look at that are going to affect our stroke volume. We'll look at preload, contractility, and afterload. Preload and contractility we'll see vary the same way. So like if preload goes up, cardiac output goes up. Okay, they vary in the same way. If preload goes down, cardiac output goes down. Same thing with contractility. If contractility goes up, cardiac output goes up. Contractility goes down, cardiac output goes down. Afterload's the opposite though. Okay, afterload is different. They vary inversely. They vary in opposite ways. So if afterload goes up, cardiac output goes down. Okay, they go in opposite ways. If afterload goes down, cardiac output goes up. So we're going to look through each of these individually and I'll explain to you what they actually are. But this is kind of the general trend that we're going to see. Okay, preload and contractility vary in the same direction as cardiac output. Afterload is inversely. So what preload is the amount of stretching in the ventricle while it's filling. Okay, so like at the end of diastole, right, when you're filling the ventricle up, it's resting, it's being filled up with blood, how much stretch do you have in that ventricle? The theory here is that the amount of stretch that you have is going to be proportional to its volume, right? That makes sense. The more volume you put in, the more stretch you put in, right? The more the preload is, and they say that the more the preload is, the more your stroke volume is going to be. This is called the Frank-Starling principle. And the easiest way to say this is more in, more out. The more you cram into that ventricle at rest, the harder it's going to contract and the more it's going to pump out. And the way that I kind of describe this is like this rubber band. Okay, if I stretch this rubber band this much, I've put some tension in it, right? There's some tension in all of these elements, and it contracts with a little bit of force. If I stretch it this much, there's more tension, right? And all of these elastic elements, that hurts. It's not that much. Okay, the more I pull those elastic elements, the harder they snap in, right? So if you picture a heart, a pumping mechanism, The more you stretch it out, the harder it snaps in, the more it's gonna pump out. Okay, that's what this means here. So as end diastolic volume increases, right, as the volume we cram in there increases, stroke volume is gonna increase, because the more in, the more out. As stroke volume increases, what happens to cardiac output? It increases. Okay, it's kind of similar to the atrial reflex, right? The more we crammed in there, we said the more we need to get out, so we increased heart rate. This is just because of stretch instead, but it's still, the more we put in there, the more we ultimately are going to try to get out, so that we don't have these backups. And there is a limit to this. It's not like this is just like forever line where we just keep increasing it. The heart's limited in how much it can actually stretch, right? There's the cardiac skeleton, and there's the pericardium, and like you can't just keep stretching it forever to increase cardiac output. There is a limit, but within normal limits, this occurs. All right, so here we see how this principle works at rest and then with exercise. Again, very, very similar to what we saw with the atrial reflex. So at rest, your end diastolic volume is relatively low, right? You've got a normal kind of volume going into your heart, dropping down into your ventricles. So the myocardium doesn't stretch too much, right? It's just kind of at its normal width. It contracts with less force because you didn't stretch it too much, right? It's the rubber band that we barely stretched out, contracts a little bit. So stroke volume is relatively low. We'll cover this more when we do vessels in the next chapter. But again, with exercise, what happens is your muscles literally squeeze your veins and they push that blood up. And the more you breathe, you suck that blood up. It's like suction in your abdominal pelvic cavity, in your thoracic cavity. So the more you exercise, the more active you are, you pull all that blood back up into the heart. So with exercise, your end diastolic volume increases. You've got a lot of blood getting crammed into that heart. So you're stretching out that myocardium. The more you stretch those elastic components, the more force they contract with. Okay, the harder they snap. So you increase your stroke volume. Is that good? Okay, so contractility and afterload, and that's it. Contractility is the force that you produce in a contraction at a specific preload. Okay, so there's kind of two different things that affect the force you contract with. The preload, right, the more you stretch, the more it snaps. That's just because of elasticity, just the elastic components. Contractility is how hard those muscle cells actually contract. Okay, so they can contract very forcefully or not quite so much, just like your muscles, right? You can push something a little or you can push it super hard. So your heart can do that as well. It can adjust how hard it contracts. This is affected by multiple things. We're going to really look at autonomic activity and kind of relate that to hormones, but they're directly related to each other. We see that the sympathetic nervous system affects contractility much more than the parasympathetic. The parasympathetic effects are pretty negligible. We really just adjust the sympathetic nervous system when we're adjusting contractility. And we do this via both epi and norepi. Okay, so not just norepinephrine like we saw with heart rate. Epinephrine is involved as well. And we can release epi and norepi in a couple different ways. We can release them as neurotransmitters. Okay, so the postganglionic fibers, the neurons, right, can release the epi and norepi as neurotransmitters, right? From the neuron across the synaptic cleft, that's how it's working. Or the adrenal medulla, which is part of the adrenal gland, releases epi and norepi as hormones. Seems kind of weird, right? It's the same thing. How can it be a neurotransmitter and a hormone? If it goes across the synaptic cleft, it's a neurotransmitter. The adrenal glands are right on top of your kidneys. They can release these same molecules, epi and norepi, into the bloodstream. If they're traveling through the bloodstream instead of across the synaptic cleft, now we call them hormones. Okay, but in either case, it's the same chemical, and it's going to end up causing a lot of the same effects. It's just when it comes from the adrenal gland, it lasts longer. Okay, so you have minutes instead of just like an instantaneous effect. But in either case, this is the sympathetic nervous system. This is our fight or flight. So do you think your heart's gonna pound or it's gonna chill out and beat soft? It's gonna pound, right? You felt your heart pounding when you get really, really scared, right? Or when you're running, your heart pounds. So this causes your ventricles to contract with more force. If you contract more forcefully, do you think you're gonna increase the amount you pump out or decrease it? Increase it, right? If you squeeze harder, more is gonna come out. So you increase stroke volume. What does that do to cardiac output? Increases cardiac output. Okay, so we can increase our stroke volume and our cardiac output by increasing contractility, right? Norepinephrine and epinephrine can go to the heart and say contract harder, or we can do it because more blood goes into the ventricle. Because when it stretches more, it contracts harder, just like our rubber band. Remember I said afterload is different. Afterload varies inversely, right? Or in opposite direction as stroke volume and cardiac output.
This is a terrible place to pause this, but